We have the pleasure of having Dr. Rishi Gupta give us a talk this morning. Dr. Gupta is an associate professor and vitreoretinal specialist in the Department of Ophthalmology and Vision Sciences at Dalhousie University in Halifax. He attended medical school at the University of Toronto, completed his ophthalmology residency training at the University of Ottawa, and received a vitreoretinal fellowship at McGill University. Dr. Gupta actively participates in research and has over 50 publications in prominent peer-reviewed journals on a wide array of topics. He has received awards for his work in medical education, research, teaching, surgical videos, as well as excellence in patient care. Dr. Gupta's book, Reflections of a Pupil, was named one of the top must-have books for beginning ophthalmologists and has even become a required reading in some residency programs. As of last night, officially, I have ordered your book, so I look forward to reading that. But thank you so much for being with us today. And I can say for everyone here that we're really looking forward to hearing your talk, The Notorious P.E.D.
That's great. Thank you so much for that kind introduction. The main reason I'm here to talk is just for book sales, so I'm glad it's working. These are my financial disclosures, none of which are relevant. Like Alex said, I did medical school at the University of Toronto 20 years ago now, so to be able to give grand rounds here is really, really special for me personally. I'm very grateful to Drs. Peter Curtis and Amandeep Rai for helping provide this opportunity. So that's for all the 90s rap and R&B fans out there. So pigment epithelial detachment has been a topic of interest for me over the past decade, really, as a retina specialist. There are all these cases that have stuck with me because they surprised me, fascinated me, confused me. And so in this talk, I want to bring you right into the clinic, and I want to show you some things I've learned over the past years with a focus on classification, imaging, and treatment. And I recognize we're on Zoom, which isn't the most conducive to interaction, but I welcome any interruptions at any point for any clarification or any questions. So a reminder, this is almost the entire fundus, and typically we're going to be taking OCT scans through the macula, where we'll see the vitreous, the retina, the choroid. And this last layer, we have these four outer hyperreflective layers, is the RPE and Bruch's membrane complex. The RPE has a number of functions, including recycling the outer photoreceptor segments. And when we have a PED, that's a separation of the RPE from Bruch's membrane, as we can see here. So I tell our residents, you really, to understand these OCT images, you want to really understand the math behind it. And if you're going to memorize one equation from this paper, I think it's this one. So I'm just kidding, of course, there's no math in this lecture. We're just going to see lots and lots and lots of pictures. So when we talk about the classification of pigment epithelial detachment, as we can see in this picture, we see the RPE, and I'll show you that line there. We see this deviation here. Under that, we see this hyperreflective change. And so with this dome-shaped homogeneous hyperreflectivity, this PED, we're going to call that a drusenoid PED. In our classification, we're going to contrast that to this other image where we see this hyporeflectivity under this dome-shaped PED. And this one we're going to call a serous PED. In our classification, we also have this type of PED, more irregular looking one, and we can see subretinal fluid here, subretinal hyperreflective material. And this one we're going to call a fibrovascular PED once you have new vessels, which you can readily see here on the OCTA. And the fourth one in our classification we're going to think about, we can call this hemorrhagic PED when we see a lot of blood, essentially. So that's our classification. When we think of these four entities, what conditions do I want you to think about? I want you to think about three. So macular degeneration, central serous, and polypoidal choroidal vasculopathy. When we look at these three diseases, and I'm looking at an OCT, the first thing in my mind for AMD, I'm looking for the hallmarks of AMD, so drusen or reticular pseudodrusen. With CSR, I'm thinking about looking for a thicker choroid, as well as polypoidal, and we're going to look for hemorrhagic sharp-peaked PEDs, and we'll see that in some later slides. Here's a great article from Larry Yanuzzi's group. Again, you see those big three, so AMD, PCV, and CSR. When we look at AMD, we're going to think about, are there new vessels or not? So is it non-vascularized, so no new vessels where we'll have drusenoid or serous, just like we saw in our classification, or is it vascularized? And typically we'll see PED with type 1 and type 3, and we'll touch on that shortly. And polypoidal, we're typically thinking vascularized. CSR usually is non-vascularized, but certainly we can have new vessels in some cases. So why is this important? Well, if we have new vessels, that's where we want to consider, obviously, treating with anti-VEGF therapy. Here's another great paper with David Saraf and Bailey Freund as senior authors. And again, we see those three big conditions, so AMD, PCV, CSR. There are certainly other conditions that can give you pigment epithelial detachment, much less common. So we're going to forget about those for this talk. We're just looking at the degenerative ones, so those three conditions. Now, there's a consensus nomenclature paper that was put out in 2020 on neovascular AMD with Rick Spade as the lead author. And there's a couple of things that I want to just review here. The first is the residents may see, your staff transitioning to this term of macular neovascularization. You may hear that. Often you'll probably still hear choroidal neovascularization, but the nomenclature paper, the suggestion is that we're going to be shifting to MNV. So you'll hear me saying MNV during this talk. The old classification by fluorescein of classic versus occult is there. And then on OCT, we're often talking about type 1, type 2, type 3 MNV. So what is that? Well, type 1 is when we see these vessels growing within the sub-RPE space. Type 2 is when they've broken through Bruch's membrane and the RPE monolayer, and they're proliferating in the subretinal space. And type 3 is what we call that wrap lesion, where we have neovascularization originating from the retinal circulation growing towards the outer retina. Okay, so we have our classification, so drusenoid, serous, fibrovascular, and hemorrhagic. And now what I want to do is bring you right into the clinic and show you a whole bunch of cases, which really taught me a lot. So our first case is simply that first OCT I showed you, where on the color we can see drusen, the autofluorescence. We see all these little hypo-autofluorescent spots, which we'll talk about in a second. The fluorescein did not show any MNV, just showed staining. And so when we look at this was again that first image. We have that P.E.D with homogeneous hyper-reflective material. We have these retinal, subretinal drusenoid deposits or reticular pseudodrusen, which we'll touch on in a second. And there's drusen. We also have these hyper-reflective foci, which are interesting, and we'll come back to a little bit later in the talk. I love this autofluorescence image showing all these little hypo-autofluorescent spots, which are the reticular pseudodrusen or subretinal drusenoid deposits. So when we look at these reticular pseudodrusen, we are seeing deposits above the RPE line. So the RPE line is actually not deviating. We're seeing these little spots above the RPE line, as you can see here in stage 2, as well as stage 3. So why are these important? Well, these are a risk factor for advanced AMD. So you have to be aware of that. So on this OCT, we have the hallmarks of AMD, we have drusen, we have subretinal drusenoid deposits. So we're going to call that non-neovascular AMD and a drusenoid PED. If you look at the AREDS report 28, over 5 years, about a fifth of these will develop central GA and obviously vision loss, and about a quarter will develop neovascular AMD. Now, I always had this question, well, when do I call something a drusen and when do I call it a PED? And we go back to that nomenclature paper where we see at 350 microns, we are going to start calling something a pigment epithelial detachment. Great, so that's case number 1. We're on case number 2. So this is a 54-year-old female, and we can see this sort of vitelliform-like change in the macula of both eyes. Here's your red free. And when we look at the spectral domain OCT, we can see these PEDs with this homogeneous hyper-reflective material. Well, hang on just a second. Are these actually PEDs? Let's contrast that with case number 1. So case number 1, we're going to follow that RPE line. We're going to see it deviate very clearly. But look at case number 2 here. As we follow this along, we just kind of lose the RPE line. So this is in fact shadowing artifact from that vitelliform material that's attenuating the RPE signal. This is not a PED, this is actually subretinal hyperreflective material. We can see that on the autofluorescence very readily. On our fluorescein, we see that there's no leakage, no MNV, there is blockage, a little bit of staining. And so for our residents out there, you want to think about in this vitelliform sort of case to do electrodiagnostics. Here we had a normal ERG, a normal EOG. If we had an abnormal EOG and we're thinking about the Arden ratio, we might be thinking of Best disease. That's what we're trying to rule out. And so we have a diagnosis of adult onset vitelliform macular dystrophy. So you just want to be careful about, is this PED or not? That's the reason for showing this case. Another very interesting thing is over time, the subretinal fluid, the subretinal vitelliform material can actually disappear. So we go from something like this to 3 years later, macrophages have come in and eaten up some of that vitelliform material. So you have this hyporeflective space. So it's important if the patient presents to you with an OCT looking like the bottom image that you're not thinking, oh, this is fluid that I need to inject. This is not a VEGF mediated process. All right, so case number 3. Here we have a 55-year-old, and there's something going on there in the left eye, which you can't really appreciate too well on the color. A little bit more on the red free, but certainly the autofluorescence makes it pop. When we look at our fluorescein angiogram, you can see this sort of smokestack kind of leak. And here on the EDI, enhanced depth imaging OCT, we see subretinal fluid, this dome-shaped serous P.E.D, right, that hyporeflective space underneath. Importantly, there's no drusen. And when we measure our choroid with our EDI OCT, we can see that this is on the thicker side. So pretty classic images and a classic story. Recent stress, cortisone injection in the shoulder. So as we're looking at this, are we thinking this is non-neovascular AMD? Is this exudative neovascular AMD? Or is this CSR? So you're thinking about that, and probably everybody's coming up with CSR. If that doesn't resolve on its own, then I'm usually going to lean on photodynamic therapy. And so this is a home run case, half fluence PDT, and doing great after the treatment. So we can see that EDI OCT of the choroidal thickness can be very helpful. There are cases where you're wondering, is this AMD, is this CSR? And doing the EDI OCT can give you some tips. As well as I love ultra wide field autofluorescence with CSR versus AMD. You can see these gravitational descending tracks, which leans you a little bit more towards central serous. Here's another great example of that. And another great example of these descending gravitational tracks, the legacy of fluid dripping down. So case number 4, this is a 46-year-old male, and he's given a diagnosis of central serous chorioretinopathy as this dome-shaped serous P.E.D. There's no drusen, importantly. 2 months later, he's got subretinal fluid that's accumulated. And 5 months later, it looks great. Subretinal fluid and the P.E.D. have resolved with observation. So no treatment given. When we look through the images, these are the autofluorescence images. On the fluorescein, there was no MNV. We did an ICGA, again, no MNV. And OCTA, again, no MNV. And so the natural history of these pigment epithelial detachments in central serous, about 65% can have complete resolution. So we're going to call that central serous chorioretinopathy and a serous P.E.D. Now, case number 5, we're going to actually take along with case number 6 briefly before going into more details. And my question for you is, how are you going to treat these PEDs with this cap of subretinal fluid? And are case number 5 and case number 6 basically the same, or would you treat them differently? So very quickly, we're going to rifle through the OCTs, and then we're going to go with a deeper dive through each case. So here we go. Here's case number 5. You can see this PED, a cap of subretinal fluid. And case number 6, I think you'd agree with me, looks very similar. So PED, cap of subretinal fluid. All right, so let's dive into case number 5 a little bit more closely. We have a 50-year-old female. You can see something going on in the macula of that right eye. I'll blow that up for you. And you can appreciate pigment epithelial detachment and drusen. When we go to our autofluorescence images, for what it's worth, we then go to spectral domain OCT, and here you can see that PED. You can see a hyporeflectivity below it. And interestingly, you can see the sub-RPE hyperreflective material. And that certainly caught my eye. Here's subretinal fluid. We have subretinal hyperreflective material. So subretinal versus sub-RPE, which is what I just highlighted. Drusen, hyperreflective foci, which I promise we'll come back to. Focal RP thickening, which I promise we'll come back to. The importance of that. Other eye has drusen. Okay, so back to the right eye. So as you're sitting there, I want you to think. So do you think this is neovascular, non-neovascular AMD, and you're just going to watch this eye? Is this exudative neovascular AMD and likely will respond to anti-VEGF, so you're injecting this eye? Or is this a different disease and this is CSR? Now, a question I had was, does this sub-RPE hyperreflective material guide us in any way? This is a lovely paper. I love this one from Bailey Freund and colleagues back in 2010. He says, note the reflective material. So look at the white arrows along the back surface of the RPE that is suggestive of fibrovascular tissue. Seems to be contiguous with the type 1 sub-RP MNV. So when I saw that, I thought to myself, okay, this is probably fibrovascular tissue. This is going to be something that's VEGF mediated. We should be thinking about treating. Here's another amazing paper, David Saraf's group from 2021. And what we're seeing, again, is pigment epithelial detachment, subretinal fluid, and then we see all this sub-RPE hyperreflective material. So in my mind, I'm thinking, okay, maybe that's fibrovascular tissue. Maybe this eye is going to respond to injections. But this whole paper is about non-neovascular AMD, eyes without new vessels. I'll show you another example from that paper, which looks very similar to the case that we're looking at right now, case number 5. So pigment epithelial detachment, they're showing subretinal fluid, that focal RPE thickening, hyperreflective foci. And again, they're showing that this is non-neovascular AMD. So let's go back to our case and we'll get more imaging to rule out macular neovascularization. So here's your fluorescein, which shows no MNV, just pooling of that P.E.D. We see on the ICG, no MNV. And we see on the OCTA, there's no flow. So in fact, this is non-neovascular AMD and will not respond to anti-VEGF. And in case you're sitting there wondering, I did do a trial of anti-VEGF, which did not result in any change. So Phil Rosenfeld in Miami says, when subretinal fluid overlies the top of a PED, rather than the edge of the PED without associated intraretinal fluid, blood, or a notch, then most likely the PED is not vascularized and will not respond to anti-VEGF therapy. So I thought that was a really instructive case. So this is non-neovascular AMD and a serous PED. Case number 6, we saw that case number 6 looked very similar. This is a 79-year-old gentleman, and when we see the left eye there, I'll blow that up for you, something going on there. We can appreciate pigment epithelial detachment. There's no hemorrhage. Here's the autofluorescence for what it's worth. On spectral domain OCT, we can appreciate drusen in the right eye. In the left eye, we're going to see pigment epithelial detachment, subretinal fluid. We can see subretinal fluid, the cap of subretinal fluid over that PED, focal RP thickening. And so looks quite similar to the last case. So maybe this is non-neovascular AMD and will not respond to anti-VEGF. So maybe just commit in your mind, which of those 3 would you do? Are you going to inject this eye, not inject this eye? Are you doing PDT? What are you going to do? Well, let's get more information before we make a final commitment to what we're going to do. Let's get more imaging. And we're going to try and rule out macular NV. So here's your fluorescein. Let's blow that up. And we actually see a little notch here, as well as here. On the ICG, we can appreciate those new vessels right there. Now, the OCTA was challenging. I did not appreciate flow. And we can see a nice comment here from an article in 2019 in Retina that the diagnosis of type 1 MNV using OCTA requires the use of manual segmentation. I'll tell you, it's quite cumbersome on the Heidelberg. I even tried and was not able to pick up the flow, and a multimodal imaging approach, especially when the height of the PED is more than 250. So our imaging technologies are getting better and better, but there's no doubt when you have these big PEDs, sometimes catching the flow is not always easy, and that's where multimodal imaging can play a real role. So this patient ends up being exudative neovascular AMD and will likely respond to anti-VEGF. So we're going to call this exudative neovascular AMD and a fibrovascular pigment epithelial detachment. So I've got a home run for you. Post 1 anti-VEGF injection, we can see marked improvement of that pigment epithelial detachment, some residual subretinal fluid there. So I found these 2 cases really instructive, looked very similar at first blush. Clues to fibrovascular PED: if you see hemorrhage, intraretinal fluid, subretinal hyperreflective material. We've seen, you're taking all of these things in combination. Any one of them may not give you the answer. Irregular PED or a notch. And certainly the gold standard is, of course, if you see those new vessels on either FA, ICG, or OCTA. We're going to jump to case number 7. So this is a 73-year-old female. She has non-neovascular AMD, this drusenoid PED. We can see Brooks membrane there. We can see drusen. So 19 months later, she looks like this, and we're wondering, well, maybe this is non-neovascular AMD now. We see growth of this drusenoid PED. We can see a little bit of subretinal fluid, some hyperreflective foci. At 27 months, we have some subretinal fluid here. We have hyperreflective foci. I'll show you the color image. Lots of drusen in the left eye, and the right eye will blow that up for you. And we can note that there is the P.E.D, there's drusen, but there's no hemorrhage. Here's the red free. On OCT, we can see drusen. We can see P.E.D, we see subretinal fluid, subretinal hyperreflective material. We see that sub-RP hyperreflective material for what it's worth. Sometimes it's neovascular tissue, sometimes it's drusen. Hyperreflective foci, subretinal fluid at the side as well as at the cap of the P.E.D. Okay, so our questions again, do you think this is non-neovascular AMD? Is this exudative neovascular AMD? Is this CSR? What are you going to do? Let's get more imaging. And so on our fluorescein, we can readily see this occult MNV. On our ICG, it's a little bit subtle, but there are new vessels here. But the OCTA is a bit more clear. We can easily see flow here, new vessels on the en face. So this is exudative neovascular AMD and will likely respond to anti-VEGF. And I got another home run for you. So post one anti-VEGF injection, this is what we're looking like, doing very good. We're going to call this exudative neovascular AMD and a fibrovascular P.E.D. Case number 8 is a 78-year-old gentleman. We see large, soft drusen in the macula of both eyes. Here's your red-free image. And on OCT, we actually see a little bit of subretinal fluid, both in the right eye as well as the left eye. Now, we've known for years that drusen can have some subretinal fluid overlying the area. This is a paper from 2011 in ophthalmology. And there's a comment, large confluent drusen can be accompanied by subretinal spaces that appear to be filled with fluid. They can be misdiagnosed by OCT as active MNV. So back to our case, there's no MNV on fluorescein. So we're going to call this non-neovascular AMD drusenoid P.E.D. So I think important to highlight, one of the big things I want to show is you can see fluid or these hyporeflective spaces and not have new vessels. And that's not a VEGF mediated process. So we just have to be careful, when we initiate and start anti-VEGF therapy. This is case number 9.
Rishi, I'll just hop in here.
Absolutely.
So we have just a question from Deepa. She was wondering if you could comment on subretinal fluid at the base of the P.E.D, at the side of a P.E.D. How do you tell if that's a structural change or if that's actually exudative from a neovascular process?
Hi, Rishi.
Hi, Deepa. How are you?
Amazing. Love the slides. Love everything you're doing. I just have all these questions throughout, so I'm just going to ask this one. Thank you.
Absolutely. No, that's great. So nice to see you, Deepa. And a great question. I think something that we all struggle in when we're looking at OCTs, is this just mechanical because of the deviation, of the tissues, or is this actually, a VEGF mediated process and active leakage? And I think what I lean on is if I have a case that's sort of confusing me, stumping me, I do go through the process of doing all this multimodal imaging. Are we doing this on every case? Absolutely not. Obviously not, right? I'm showing you these cases just to highlight things that I've sort of learned along the way by doing the multimodal imaging. So I think, to answer your question, I'd lean on the multimodal imaging, and if there's new vessels there, really the question is, are we injecting or not? And in the cases where, I'm not certain, I think a trial of anti-VEGF is very reasonable.
And then one more question while I have you.
Yeah.
You talked about doing a trial. We sometimes don't know if something's anti-VEGF responsive unless you try it. And so that is also my approach, is if you're not sure, if you're in between, try it and see what happens. So if at some point you could comment on trialing very symptomatic PEDs that have no fluid anywhere, nothing, no MNV on multimodal imaging, but the patient is symptomatic from very disturbing distortion. Would you do a trial, clearly labeling it as experimental, just to see if it would work?
That's a great question. So, we've all seen those patients and you're sitting there looking at their PD and you're just like, why does it have to be right there? and you know, right in the center of the fovea. It could be anywhere else. Very frustrating for them and for us. I don't typically trial anti-VEGF in those cases. And some of them will, you know, resolve on their own, as we saw, you know, on that slide about central serous, for example. You know, it depends on what you're going to label this, you know, idiopathic P.E.D, for example. The concern is if they go away, you know, whether they'll leave atrophy and vision loss. And we'll see a good case of that coming up. Thanks for those questions, Deepa. Really nice to hear your voice.
Thank you.
And sorry, just one last quick follow-up just
Absolutely.
before we
Yeah,
continue.
it's fun.
So
That's great.
when you do trial an injection, this is from Brad Cates. Do you just see them back 2 weeks later after one injection, and that's what you would do for a trial?
That's perfect. Yeah, you know, I probably wouldn't have articulated that, so I'm glad you said that. That's exactly what I do. I see them back in a couple of weeks, thinking that that might be, you know, where we'll see the maximal effect. Of course, in the background, I mean, we all have patients who, you know, you're injecting, and you're not seeing. I've shown you a couple of home runs, but I'm going to show you a great case where you know, significant changes happen months and months and months later. So, you know, none of us have a crystal ball. We're all trying to sort of weigh risks and benefits, but certainly if I'm doing a trial, then it's shot 2 weeks later, OCT, you know, are your symptoms any better? And objectively from an OCT perspective, are you any better? Visual acuity is, you know, plus minus, of course, but that's a great comment. Thank you, Dr. Cates.
Great, thanks.
Great. So 80-year-old female, large soft drusen. We can see in the right eye, the left eye. I'm going to blow that up for you. You can see obvious hemorrhage here. When we look at the fluorescein, we can note occult leak here. And this is one of the first OCTs that we actually looked at when we were looking at our classification. The reason I want to show this is because it has kind of a cool imaging feature here. We see two things that I've put question marks around. And so Ihsan Rahimi and colleagues talked about this multi-layered lamellar scar that you can see. So, you know, when you're in clinic on Monday or even today, you know, look out for this. You'll see this in a lot of your injection patients. You have sort of contracture of this multi-layered lamellar scar that will lead to this choroidal cleft. Just kind of an interesting imaging finding. So in this patient, we do have flow, of course. We have a tangle of vessels. And so this one we are going to call exudative neovascular AMD and fibrovascular P.E.D. Case number 10, so we have non-neovascular AMD, we have drusen here. 14 months later, you wonder about SIRE here, and we're going to break out what SIRE is shortly. This is 17 months, this is 19 months, and now we have subretinal fluid, P.E.D, intraretinal fluid. Sorry, I passed through that quickly, so intraretinal fluid as well. This is the color image for the residents. If there's any sharp shooters, you can see a little disc hemorrhage in the left eye, but we're looking at the macula, of course, because I'm a retina specialist. And here we can see fibrosis. There's no hemorrhage. Here's your red free for what it's worth. And then when we go to the fluorescein, again, we can see this occult type leak. We do see vessels on the en face OCT. And so we have a diagnosis of exudative neovascular AMD, fibrovascular P.E.D. So we're going to start monthly injections, and this speaks to a little bit of, you know, changes over time. So 2 monthly injections, 9 monthly injections, 13 injections, and we still see that P.E.D, but you're going to start to see it coming down now at 15, at 17 monthly injections, and she was on the dot, you know, every 31 days. Finally, at 19 shots, we actually have, you know, a beautiful resolution and still great vision of 20/40. So a nice example of P.E.D that slowly resolved over many, many months and many injections. And if you look at post hoc analysis of Harbor, we see at 2 years complete resolution of P.E.D in about 50%. So, you know, as you're injecting, you know, we do see people whose P.E.Ds resolve, but we see lots where it just kind of hangs around. In VIEW trials at 1 year, complete resolution of P.E.D and 40% in the monthly aflibercept and 28% in the ranibizumab. So back to our case, we alluded to this concept of SIRE. What is SIRE? Well, it stands for shallow irregular RPE elevation. So when we have this shallow irregular RPE elevation, we're sort of seeing Bruch's membrane and the RPE in a very shallow way. So a height of less than 100 microns to this P.E.D and in a wide way, so 100 microns in the transverse diameter. And this is suggestive that we have new vessels. So here's an example of SIRE. And when you do OCTA through that area, you actually see MNV. So now we have a situation where we have MNV, but no subretinal fluid. So I showed you cases where we had no vessels and we had subretinal fluid or hyperreflective space. And now we have a situation where we have MNV, but no subretinal fluid. And this comes up when you're injecting an eye, and you're taking pictures of the other eye, of course. And one day you've done an OCTA and you say, oh, there are vessels in the other eye. So when we think of AMD, we have non-neovascular AMD, which may be non-exudative or exudative. And then we have neovascular AMD, which may be non-exudative or exudative. So when I first encountered this, I thought, okay, well, that's great. We're catching this early. We'll start our injections, right away, and that's wonderful. A great paper from 2020 in Ophthalmology Retina talking about, although non-exudative MNV seems to be a precursor for the formation of exudative neovascular AMD, there's evidence suggesting a protective effect in slowing the progression of GA. And non-exudative lesions should not be treated until symptomatic exudation develops. So I found that really interesting. You have a disease which is very profoundly going to affect a lot of people's sight, to legal blindness. Here are new vessels. Why not treat them? But generally the retina community, we will watch those until you see exudation. So case number 11, we have non-neovascular AMD, this P.E.D. You can see that drusenoid sort of hyper-reflective material on the undersurface of the RPE. We can see Bruch's membrane. You can see some reticular pseudodrusen. And then 18 months later, we're seeing perhaps non-neovascular AMD, maybe neovascular. You have that sub-RP hyperreflective material. We have subretinal fluid. We have hyperreflective foci. And I'll tell you that we did multimodal imaging and there was no MNV. So this is actually non-neovascular AMD. I did do a trial, which didn't result in any change. And so we're 29 months from presentation. And what I want to show you here is an interesting evolution. We're going to remind you about focal thickening of the RPE, remind you about hyperreflective foci. And what we're going to appreciate is this thing is going to start to collapse, which unfortunately is the natural history in a number of these, and collapse with atrophy, unfortunately, and vision loss. So here we are at 60 months, and we have complete RP and outer retinal atrophy. We see this choroidal hypertransmission secondary to atrophy. So there's consensus nomenclature, just so you're aware of, on atrophy as well. Vas Sada is the lead author in 2018 in ophthalmology, if you're interested. So back to that David Saraf paper on non-neovascular AMD with subretinal fluid, a really great paper. And if anybody wants any of these papers, I can send you an email with all of them. Intraretinal hyperreflective foci, focal RP thickening, these are highly associated with atrophy. And so that's why I've been highlighting it with all of these slides. We can see those features in this case, which over time, unfortunately, went to complete RP and outer retinal atrophy. All right, so we're on to case number 12. This is question mark non-neovascular AMD. You wonder about SIRE here. 2 months later, we have subretinal fluid. Anti-VEGF is initiated, and then the picture looks like this. So I'll let you think about that for a second. What is the diagnosis here? Highlight the RPE for you. And on this side, we're kind of missing the RPE, so this is an RPE tear. Here's what it looks like on fundus photography. You can see that RPE scroll, the RPE defect. Pops nicely on the near infrared as well as the autofluorescence. And there's a Halifax connection here, so I'd be remiss if I didn't talk about tears of the RPE. And Hoskin Mott, who retired in 2015, described this all the way back in the year I was born, actually, 2 months before I was born. So after an RPE tear, should we continue injecting these eyes? This was something that I always wonder about. Should we stop it? Should you do something else like PEDT? Well, David Saraf presented a grading system for RPE tears, just so you're aware of, and basically it's just small, bigger, bigger, bigger. It's a really nice paper by Paul Mitchell's group, and shows quite nicely a case of exudative neovascular AMD, fibrovascular PED, initiated anti-VEGF, and then 1 month later, it looks like this. So the question I have for you is this a concern? What are you worried about? Well, that sawtooth wrinkling is a risk factor for a tear. So when you see this, you have to tell the patient, I'm worried that this may happen. 2 months later, grade 4 RPE tear and vision loss. Here's another example from my clinic. So exudative neovascular AMD receiving anti-VEGF, and we can appreciate these corrugations, let's call them, of the RPE. I warned this patient, and sure enough, a month later, we have that RPE tear. I'll just flick back and forth for you so you can look at the color image, and you can see that RPE tear as well as on the red free. And so the recommendation is, in fact, to continue anti-VEGF treatments in cases where there is active disease. And I have some patients who have really stable vision, and when you look into the eye, you wonder how it's possible. And they comment that there's no clinical data demonstrating a difference in the risk of RPE tear based on anti-VEGF injection agent used, which is always a topic of controversy, and whether or not the anti-VEGF contributes to causing tear, which is always a discussion point as well. A lot of people advocate using sort of half-dose injections when you have a big P.E.D, which I think is very reasonable. But there's no evidence to support that the VEGF is creating that tear. So if you have active disease, continue through that RPE tear. Case number 12, just looking at the time here.
Richie, one quick question on RPE tears from Stephen Kosar. So can you comment on RPE tears in patients that are not receiving anti-VEGF, in terms of if you have a really, I guess, peak P.E.D, in terms of incidence with treatment or non-treatments, in terms of maybe how common you would see an RPE tear and what you would do to manage that?
That's a great question. Yeah, I mean, I'd have to look at a paper. Essentially, the higher the P.E.D, the more stress these things are under. So I think it's something that, you want to counsel the patient on. You want to look for those corrugations or those wrinkles and be on alert for the tear. But these can happen with or without treatment. It's essentially, just the strain on that RP that can let go, unfortunately.
Okay, great.
So I think we're doing the question period as we're going. So Alex, just stop me whenever we have to stop, but keep the questions coming. This is great, because maybe we'll get through all the cases and still have all the questions sort of embedded in. I'm a real nerd when it comes to imaging, and so I just had to show this case because I thought it was so fascinating. This is from a good friend, Mark Simon, friend and colleague, who's a retina doc out in Edmonton. 32-year-old female. This is the really neat imaging finding in this case that I'm highlighting here for you. You have a P.E.D, a serous P.E.D, you have subretinal fluid, intraretinal fluid, subretinal hyperreflective material, and a very thick choroid on EDI OCT. So Mark and I and a bunch of us, were reviewing this case all together. Everyone was giving thoughts and input as to basically whether you're going to think about injecting or not. And on OCTA, there was no flow. This was observed, and so 2 months later, in fact, things look great, and 20/30 vision. So this is called a micro rip, which you can uncommonly see in central serous retinopathy. Just because of pressure changes, you get this blowout of the RPE, and a lovely case from 2020 in JAMA Ophthalmology showing observation 2 months later. So in your CSR patients, look out for this little micro rip. You might see it from time to time. And do all your multimodal imaging if you can. Know that this will probably resolve, and hopefully with a favorable prognosis. So we're going to call that CSR with a micro rip of the RPE and a serous P.E.D. No new vessels. Case number 13. We have a 47-year-old female, subretinal fluid, these P.E.Ds. And my question is there anything special about these P.E.Ds? Do they look a little bit different? A nice paper about polypoidal choroidal vasculopathy, where they talk about sharp peaked P.E.Ds. These are one of the features that you look for on OCT imaging when you're thinking about polypoidal choroidal vasculopathy. So these are these sharp peaked P.E.Ds. When we look at the color, you can see hemorrhage here, maybe polyp. We'll do a simultaneous FA and ICG. ICG is on the right and readily highlights that polyp. So we're going to call that fibrovascular or hemorrhagic P.E.D. So look out for these sharp peaked P.E.Ds, another interesting imaging finding. There's a great case. A 64-year-old female moved provinces, came to Halifax, and had 3 anti-VEGF injections for peripapillary corroded neovascular membrane, or macular NV. We can blow that up for you in the right eye. See a lot of hard exudate, some hemorrhages here. And I'm thinking to myself, that's a little more exudate than you see in AMD. I'm thinking maybe polypoidal. And you wonder about a polyp right there. Here's your red free again, wondering about that polyp right there. We're going to do a fluorescein, and we can see something going on there. That's the other eye, which doesn't looks normal. So let's go to our OCT. Now, interestingly, we have no drusen. And in the right eye, in the effective eye, we can see these hyperreflective foci corresponding to hard exudate. We see subretinal fluid, intraretinal fluid. So a lot of edema. This is 1 month after the last aflibercept shot, has had 3 already, finds that her vision's not great, hates the shots, doesn't find they're helping. No drusen and no P.E.D, interestingly, right? We don't see a P.E.D. So why don't we take a cross-section right through that area and look for our polyp? Well, interestingly, we don't have a polyp. And if you think back to that fluorescein, looks a bit more like a macroaneurysm. And that's what we're seeing there. So talk to her about doing a laser. I think the anti-VEGF, in theory, could have helped to, dry things up. And a lot of these macroaneurysms will close off on their own, but she's struggling. It's obviously leaking. So I thought, why don't we do a laser? And then 1 month after the laser, she's 20/30 and all dried up. And this for me was always a good reminder. Sometimes you get on autopilot with your own patients, and certainly, patients that come in from outside who are already on a diagnosis and a treatment path. A good reminder that we always need to just, check things with a fresh lens. This is our last case. So a 72-year-old gentleman, left eye shows P.E.D, subretinal fluid. There's a sort of serous looking P.E.D. No drusen in the other eye. 20/25 vision on the right, 20/50 in the left. I'll blow up the left eye for you, that one with the pigment epithelial detachment. There's no hemorrhage. When we go to the fluorescein, you can see this multiple leakage points with pooling in the P.E.D. Autofluorescence demonstrating, some of these maybe gravitational descending tracts. And so as you're sitting there, you're thinking to yourself, is this non-neovascular AMD like we've seen? Or is this an example of exudated neovascular AMD as we've seen? Is this maybe CSR? Should we be thinking about PDT? For me, I was leaning a little bit more towards diagnosis of CSR. And so I'm going to show you a whole summary of OCTs and treatments. I'm hoping that this is big enough for you to see. It took a lot of work to put together, so hopefully you can see it. 20/50 vision, I'm just observing until several months later, I say, okay, well, why don't we go to PDT? He's really complaining about his vision. The vision is dragging. And a nice response, reduction of that pigment epithelial detachment. The vision now is better at 20/30. And we keep going. And then many months later, he finds that things are getting worse symptomatically, and the PED is coming back and bigger. And I said, well, last time the PDT worked, so why don't we do another half fluence? And 2 months after that last PDT, and I don't have a lot of images here, I apologize, but he had subretinal hemorrhage on clinical examination. So the OCT shows subretinal hyperreflective material, subretinal fluid, and hyperreflective foci. So I started injecting, and things looked good at first, but then started getting out of control. I was using ranibizumab. He had a lot of CME at this stage, so I decided to switch to aflibercept. And bottom line, really couldn't get back great vision, but we had things dry. So unfortunately progressed to 2200 vision. We ended up able to stop injections, and he was dry. So really frustrating sort of case. And then his right eye goes. So now I'm really worried. 20/30 vision on ICG. We can see macular neovascularization, MNV. So right away, I start with aflibercept. Has a nice response, which I'm excited about. So a couple more injections. And now I'm a little bit worried about this turbid sort of appearance under the retina. And another 3 injections. And then he has a very fascinating, again, I'm a little bit of a geek when it comes to OCT imaging. I'd never seen this before, this sort of layered out kind of appearance. I decided, he's monocular effectively, to do a brolucizumab injection. I think this is only one of 2 that I've ever done. Things consolidated, but unfortunately the vision really decreased, went down to 2200. So I just wanted to show that for the interesting imaging finding. I wonder if anybody on the line has seen that OCT before. I want to also show, just the good, the bad, and the ugly, how, despite our great treatments, we still have patients who unfortunately can progress. So I think we're out of time. I know I could talk forever, sorry. Hopefully, we've discussed the classification of PED. I've showed you imaging, and we've talked about different treatments. And takeaways, so PED can be drusenoid serous, fibrovascular, hemorrhagic. They may vanish, collapse, atrophy, and rip. You want to think about the big three, right? AMD, CSR, PCV when you're thinking about pigment epithelial detachment, and identify which have vessels and would benefit from anti-VEGF. And subretinal fluid, don't forget, can be present even if you don't have vessels. We've seen that. And MNV can be present when we don't have any exudation, so non-exudative neovascular AMD, and even when we see those vessels, we're not going to necessarily treat. And meticulous multimodal imaging can be helpful in challenging diagnostic cases. This is not for every single case. I want to make sure that everyone walks away with that. I'm not doing the $1 million workup on every patient, but I just found these are really, really instructive cases for myself. So I really want to share that. And if there are any other questions, I'd be more than happy to try and answer them.
That was amazing, Rishi. Amazing pictures, and really organized approach on kind of breaking down all these different types of PEDs. We have a few questions in the chat. I think one was from Deepa. I'm not sure if she's in the OR at this point, but oh, there she is. Okay. But yeah, she was just, I don't know if you wanted to ask the question yourself, Deepa, or just about Amsler grids. And
yeah, so I never really realized like how common vitelliform lesions and just regular PEDs are until I got into practice. What do you advise the patient on how often to use an Amsler grid, if any? So let's say it's like a 45-year-old patient. Are we really telling them to use an Amsler grid every week for the rest of their life? When they're 70 years old, I feel more comfortable. Use this Amsler grid, cover one eye every week for the rest of their life. When they're the same age as me, I feel slightly hesitant to tell them that.
Yeah, I think that's a great comment. I mean, the Amsler grid is going to give false positives and phone calls. All of our practices are going to be different. Like I do not actually have a big medical retina practice by any means. I don't have a large injection practice. Just by the nature of my practice, it is much more surgical. So I don't see a lot of people, and I just feel like a lot of my injections are bilateral injections by the time they get to me. So I whether I should or not, I guess I don't actually prescribe Amsler grid to a lot of people. And I do find more often than not when people have gotten them, which a lot of people already have from their optometrist, I find often like they'll complain of something. They say, well, I was looking at my Amsler grid and we'll have the OCT, and I'll say, well, everything looks okay from a whether you need an injection or not perspective. But of course you have drusen, right? You have signs of dry macular degeneration. So that's the tricky part is, the Amsler grid is going to show whether or not you have metamorphopsia, but you're just, you may have metamorphopsia and not have exudative neovascular macular degeneration.
Rishi, that was amazing. That was, most of what I know about PEDs, I've learned from your talks on PEDs, and I always learn a bunch more whenever I see another talk. Question I had, we when we're treating our AMD patients, or maybe I shouldn't say but I mostly ignore the sub-RP fluid. We always aim to, our first priority is intraretinal fluid. Our second priority is subretinal fluid. And, our sub-RP fluid is definitely our third priority. I know you showed some great cases where the PED did disappear. I always worry when that happens, often when that happens, you're left with this, this patch of geographic atrophy. And definitely the variety of agents we have to treat AMD have a differential effect on pigment epithelial detachments. I'm curious, how aggressively do you go after, leveling out that pigment epithelial detachment? I'm happy when it happens, but it's not something I go after. I'm curious to what your approach might be.
That's a great question. Thank you for the kind comments. You've always been a big inspiration for me. So to hear that from you is really kind. So I have the same worry as you do. When I see a PED collapsing, I'm always worried that we're going to have atrophy and vision loss. I think all of us, when we go out into practice, we fall into how we're generally going to approach things. And a lot of that comes back to our personality. Type 1 MNV is probably going to be the most common thing that we see in macular degeneration. And it's not always a horrendous disease. I mean, I'm sure you've seen some patients do very well, right? We have patients who refuse to get injections. And when I got out on my own, all you do, because you've learned pathology, treat, pathology, treat, pathology, treat, but that's not always the right thing to do in every single patient. And so you have these patients who decide, well, I'm not going to do the injection. At first you're like, oh my gosh, you're crazy. You can't imagine what's going to happen. And then they're 20, 40 for a year, 2 years, 5 years, 7 years. The challenge is we don't know who's going to have a big bleed and lose vision. So in general, I am not somebody who says, listen, you have to come every month on the dot and get your injection. I try and take it with that patient, work together and figure out what makes sense to you. I have patients who we know they have fluid and they still will not come in on any schedule that I want them to. And I accept that. I said, as long as you understand the risk, that's the plan that we're going to take for you, because that's what works for you, right? So I, in general, take all those things aside. I'm exactly as you are. CME, intraretinal fluid, concerns me the absolute most. And I will try and convince people to tighten up schedules or switch drugs if need be. Subretinal fluid, I think we've seen is tolerated better. And there's always this debate, which may be shifting a little bit back the other way. Initially it was like dry everything, dry everything, dry everything. And then there's been a recent conversation, as you know, around maybe subretinal fluid is good, right?
Not so bad, yeah.
All the landmark papers show you got better vision if you got a little bit of fluid, which is interesting. And now I don't know, maybe it might be shifting back the other way to dry, 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 but I'm okay. Like, if the other thing is, when I came out, I was thinking in my mind, my goodness, you're 20/40. Like, we have to do something about this VMT, about this subretinal fluid, about whatever you have. You're 20/40, my gosh, right? And then one day I thought to myself, I don't wear my glasses ever. I'm walking around 20/40. I'm doing okay. So I listen to the patient, and if they're super symptomatic, then 20/40 is a problem, right? Because it's probably 2015, when they started. But if they're 20/40 and happy, right? 20 over happy is what I'm shooting for in general. As long as we're not going to go blind, if we don't do anything. So very aggressive for me with intraretinal fluid, just like yourself. Okay to tolerate subretinal fluid. It'd be lovely if it was gone. And really, I don't have much of a concern with sub-RPE fluid, apart from just figuring out what is this PED we're dealing with, and is it VEGF mediated or not.
Great, thanks.
Thank you.
Rishi, I was going to ask, you showed a lot of amazing multimodal imaging for a lot of these different PEDs. In clinical practice, aside from using an OCTA when you have a fresh patient coming in to see you at the first time, how do you integrate IVFA and ICG into your practice?
Yeah, that's a great question. So with macular degeneration, by and large, nobody's getting anywhere near these images. And in fact, a lot of them aren't getting fluorescein. It's a invasive test. It takes a lot of time, and resources, as you know, are an issue, right? So you can't just line everybody up for fluoresceins and expect your clinic to flow well. And we have enough information, right, between OCT and OCTA. So in general, that's the workhorse. There's no doubt. I love a ultra wide field FA for our, vascular occlusion, diabetic patients. Just even ultra wide field pseudo color images. Our optometry colleagues leverage this all the time, right? So if you're in the eye care center here in Halifax, getting imaging is always a challenge, right? We're always overbooked by 100 patients. But if you go to the optometrist's office, they, there's a charge, obviously, to support the equipment. So you pay $50, $100, whatever, and every patient gets an Optos and an OCT. And so we'll get a referral, and, it'll say there's this break at wherever, and then, our resident might not be able to see it, and our optometrist can see it because they have the wide field image. So I love ultra wide field image for something like, schisis versus RD. I get a referral -4 myope with supratemporal schisis in one eye. That's probably an asymptomatic chronic RD, right? And the way to easily show the patient that that's actually what it is take a ultra wide field pseudocolor image on your optos and then get, wide field OCT cut through that. And you can show them, that subretinal fluid versus what schisis is. So that's probably the run of it. Lean on a lot of ultra wide field pseudocolor for documentation, medical legal purposes. So, your combined tractional rhegmatogenous detachment in a brittle diabetic, RD patients, if I'm a little bit worried about either personality or pathology, document it with that. So that's probably my imaging approach. But it's, if imaging was, if we had infinite resources, everybody would get everything. It's just not how it works. So
for sure. Okay, so I think the link may cut out in about a minute, but I just wanted to thank you again for a great talk, and hopefully see each other in person sometime soon.
That'd be great. A huge thanks. This was really special for me, like I say, and a big thanks to Dr. Peter Curtis for helping give this opportunity.
Thanks, Rishi. That was a great talk.
Thank you.
Great talk, Rishi.
Thank you. Bye, Deepa. Nice seeing you.
Amazing talk, Rishi. So good to see you. Bye.
Oh, thank you. Alex, do I log off here and then I think there's a separate link for?
Yeah, I think for the teaching, there is a separate link. That's correct.
All right, so I'll
and
just
that'll start in about 15 minutes.
Okay, perfect.
Okay.
Yeah, that's great. It was
Thanks again.
Great, thanks.
The guys survived. It was a pretty close dive.